Hello, and thank you for joining me for today's episode of Big Ideas in Eating Disorders. In this series, we hear from people in the field of eating disorders who share with us their personal and professional journeys, their experiences, their reflections, and ideas that never quite get represented this way in the standard academic publications and conferences. I'm Kathy Pike, professor of psychology at Columbia University, and I am the host of Big Ideas in Eating Disorders. Today, I'm talking with Dr. Hans Hoek. Dr. Hoek is clinical psychiatrist at an eating disorders program in The Hague and professor of psychiatry at University of Groningen in the Netherlands, and also works in a clinical capacity in the Department of Migrants and Refugees in Utrecht. Dr. Hoek is also on faculty at Columbia University in New York City. He's a busy man. Dr. Hoek has focused on psychiatric epidemiology across a range of disorders. We'll hear about his work, how he got to psychiatric epidemiology, and some big ideas that he has that have developed over the course of his career. Dr. Hoek was former president of the Eating Disorders Research Society and serves on the editorial board of the preeminent eating disorder journals. We're really thrilled to have you here today, Hans. Thanks for joining us. Let's get started at the beginning, in your growing up years, and when you first had an inkling that you were interested in psychiatry, mental health, and epidemiology.
Yeah, actually, as a schoolboy, I already wanted to become a doctor, and especially a doctor of tropical medicine. I probably read some exciting books about it. But this idea stayed till I finished high school, and then I wanted to become a doctor. But unfortunately, in the Netherlands, you had a lottery system, which meant that if you finished a certain level of high school, everybody could enter the medical school, but it was a lottery. So I had bad luck for 2 years, and then I thought, what should I study? Either biology or psychology. And then I chose for psychology to learn better to understand people, because I thought people can be very complicated. And the third year, I had good luck. I was entered in the medical school, and also I continued to study psychology because I like to study very much. But I still wanted to become a doctor in tropical medicine. So I did a lot of work for 3 years as a student in the Department of Surgery. And then I did an internship for 3 months in Suriname. And that made me change my mind a little bit. I was 3 months involved in helping women to deliver their babies. But I noticed that there were so much cultural differences between the different ethnic groups in how they experienced this process.
Hans, could you tell us about Suriname? What was it like when you were there?
Suriname was, this hostel was an old hostel where the poor people could come, and there were that many deliveries, and there hardly was any men present, which would be very different from the Netherlands. But there were coming Indian people, Creole people from the city, but also from the inland. The inland people from the jungle, they could be nearly dying from pain, and they didn't give any sound. While other people from the city, they give lots of sound, and it was a quite exciting happening at all. But the difference were, for me, very interesting. But also, I went also into the jungle, and I noticed, it's nothing wrong with being a doctor in a tropical country as a Western doctor and to help people. But the real people who did something were the people who took care of clean water, all kind of public health measure, and also the people who trained local people. So I took that. So I decided maybe it's not the best way to do something for the world. Kind of fantasy to do something. And then I did my internship in Curacao, a Caribbean island, for over a year. And then I decided, the most fascinating profession would be psychiatry for me, because I really every patient was different, and in surgery, I noticed, it looks more the same. You didn't have the time to talk really with people. So I returned to the Netherlands to become a psychiatrist. But again, you had to wait several years before to enter the clinical training. And then I got the offer from the government to become a psychiatric epidemiologist. At that time, there was no real epidemiology training program. And the government thought we need people in cardiology, in oncology, and in psychiatry to be an epidemiologist. So I was involved in my main team was schizophrenia at that time, but I also saw some other patients being in training for an psychiatric epidemiologist. And my very first patient as a medical doctor happened to be a patient with anorexia nervosa. And I was surprised. I mean, I was really shocked. How could this young woman starve herself? And then I asked for help because I didn't know anything about it. And in my whole institute, nobody knew anything about eating disorders. And bulimia nervosa isn't even known, but anorexia nervosa was known in the literature for a long time already. Mm-hmm. So I had to read the literature. What can you do about anorexia nervosa? And then I read family therapy. I hadn't experienced, I must say, but family therapy. And I tried to read how you do family therapy. And then I asked a social worker to help me. Had also no experience with eating disorders, but we did an 8 months therapy and with the parents and this young woman, and she recovered. Mm-hmm. But actually, I have no clue really what was the ingredient, what made it. I mean, the family therapy helped somehow, but also I realized social factors are important too. So that's actually the theme of my whole work, and then do it from an epidemiological perspective. What is biological? What is psychological? What is social, cultural?
Hans, you said you started your training.
Yes.
With the intent to study schizophrenia, the epidemiology of schizophrenia. Yeah. And then you had this patient with anorexia nervosa. I know you continued to study schizophrenia. How did these fields relate to each other as you were developing your expertise as a psychiatric epidemiologist?
Somehow they combined. So schizophrenia had a lot of supervisors, and for eating disorders, in my free time, actually in the evening, I was looking in data sets, what's happening with these women. And then I wrote several small papers about patterns of care. For example, that they all came into the pediatric department or the internal medicine, and mental health care didn't take care of them. But schizophrenia was my main team. And in 86, I got a grant from the government to go for half a year to Columbia University in New York. And in the program of Bruce Dorenwend, but I also met Ezra Susser there, and we started to conduct studies in the Netherlands. He was already involved in it when I met him, on the Dutch famine. You would say famine in the Netherlands, but in the Second World War, there was a huge famine, really disaster, at the end of the Second World War. And we were interested in the people who were born from mothers who were exposed to this famine, and these persons were exposed prenatally. So that was a very important study, which can tell a lot of it. But I also met in New York Tim Walsh, which made also a very much impression on me. So he was the head of the eating disorder department in New York State Psychiatric Institute, related to Columbia University. So these were very important kind of mentors for me. I also got a small grant to go for a visit to the Institute of Psychiatry in London, which is the most famous institute in Europe for research for schizophrenia. But I also met Janet Thrasher there, which was also an important mentor for me, although it was only a short visit there. So these two schizophrenia research and eating disorders helped me to advance also somewhat the field of eating disorders, because the schizophrenia field is much older, has a much stronger research tradition at that time already. So like this prenatal famine study has had an impact how I think about mental disorders in general.
Right. So it sounds like in some ways the field of eating disorders got very lucky that you had training in psychiatric epidemiology in schizophrenia, because the methodologies, the sophistication of the field in schizophrenia was something that you could bring to eating disorders that was just beginning to ask similar questions.
Yeah, and in the Netherlands, there was much more a need of somebody doing something in eating disorders than in schizophrenia. There were many people involved. The Netherlands had a good tradition in schizophrenia research. So at some point, there was this lack of treatment facilities. And actually the Queen got a lot of letters, Queen Beatrix of the Netherlands at that time. She got a lot of letters from worried parents about their daughter dying. And why are there no specialist services? So they had to call abroad to Belgium, for example, or to England, some even to Australia, where they had good facilities. And they made a National Health Counter, made a committee, which I was part of. There were all kind of professors, but they didn't know a lot. Professor of gynecology, professor of internal medicine, but they didn't have any experience actually with eating disorders. And I, as a junior doctor, even hadn't had my psychiatry training at that moment, but had wrote a few papers. So in the line of blind people, there's this one eye king. I was involved, and we made a report which had a lot of impact in the Netherlands. So we had to develop specialist centers, and the government also gave me a lot of money to do studies on it, and also to develop this National Committee of Eating Disorders to develop specialist eating disorder centers in the Netherlands. So it had a lot of impact, and it also gave me the money to do a lot of studies. Yeah.
So tell us what the first studies were that you did in terms of eating disorders and epidemiology. What were the early findings?
I mean, imagine, for example, in the US, you couldn't do these kind of studies. In the Netherlands, you have all this good registration system, whether it was to examine the effects of prenatal famine, but also this nationwide system covering 1% of the total Dutch population. And this primary care study, which is now 4 decades, brought us a lot of results which are important. So one of the findings was the early findings in the mid-19s published that anorexia nervosa occurred in cities, rural areas, and urbanized areas at the same rate. While bulimia nervosa, at that time quite recently classified disorder, was occurring 5 times more in cities than in rural areas, using the same methods all over the country.
So Hans, you conducted this research in the Netherlands. You see that bulimia nervosa is much more likely to occur in cities, anorexia nervosa across the country. You're developing these ideas around some differential influences of biology and environment potentially. And then I know you extended your research, kind of going back to this global interest that you had in tropical medicine, and went to Curacao. Can you tell us about that?
Yeah, we happened to be at Curacao. I was a general medical doctor, and I was involved for a 20-year study of the total psychiatric inpatient population. And we followed them for 20 years for schizophrenia-related research. And then I thought, well, I'm here every year. Why not study anorexia nervosa and to prove that it doesn't exist here? Because as a general medical doctor, I hadn't heard about it. I asked people, did you ever see a patient? No, they said. And then we had access to the general hospital. And we searched, it was electronically possible, 144,000 records of all kinds of patients. They were admitted for surgery, etc. But we looked for people who had amenorrhea or unexplained weight loss. And we found that there were cases also of really anorexia nervosa. And we wrote that up. And so anorexia nervosa.
This is based on clinical case or medical
Oh,
record review.
yeah.
You're
Like in the
identifying
yeah,
cases of anorexia nervosa. I mean,
yeah,
this is a real landmark finding because there had been assumptions, like you say,
yeah,
that you're not going to see eating disorders in a place like Curacao.
yeah,
What
yeah.
was the response to this finding?
Well, it had several interesting responses. First of all, it was published as a small paper in the New England Journal of Medicine, which gives it a lot of prestige. And the title was Anorexia nervosa is not culture bound.
Uh-huh.
And at that time, I myself moved to the neurobiological field saying, hey, I edited together with Janet Thrasher and Melanie Katzman a huge volume on biological neurobiology in eating disorders. But we proved to be wrong. What did we do wrong? I mean, we decided to do a much larger study in Curacao, following for 4 years all health facilities in Curacao. Because it was published in the New England Journal of Medicine, and also the BBC made a small documentary about this study, saying how important it was. Everybody thought, oh, it must be important, not because it was published, but they thought there must be something important. So there were 82 general practitioners involved in it. And when I told about the study, I said, okay, we want to participate in the study. So they all sent all people with eating disorders, private psychologists, dietitians, everybody wanted to collaborate. We got a grant for it from Curacao and from the Netherlands. And but we did find that our first study, the end result was not correct. What did we find? We didn't find a single case among the majority Black population. So 80%, to be exact, 79% of the Curacao population are Black people. 13% are mixed and 7% are white. And a small percent is Asian background. And we couldn't, in our first study, we couldn't know that because ethnicity is not politically correct to record in the medical records. So we didn't know the ethnic background. We assumed from the names. Sometimes you were, at that time you had access to the names. Nowadays it's not possible anymore. So the Black population didn't have a single case, and in the mixed and white population, the rates were exactly the same as at that time in the Netherlands and in the US. In the Mayo Clinic area study.
So now you've got data suggesting, in fact, culture is part of the story.
Yeah.
So tell us how your thinking evolved.
Well, so I had to change my mind. So no single Black case, and we did find women with bulimia nervosa, with binge eating disorders. But we didn't find a single case. So social factors are important.
So you didn't find a single case of anorexia nervosa, but you found cases of other disordered eating among the Black population.
Other eating disorders among the Black population.
Other eating disorders.
Yeah.
Okay. So tell us, this takes us, I think, it takes us to the big ideas that Crystal has for you. So please share with us where you are on that.
So in Curacao is a Caribbean country where you would say big is beautiful. To people with a higher body mass index, and especially women, are considered to be more beautiful than skinny people. So there's no pressure to be thin from the society. And mixed and white population had the same pressure. Some came from the Netherlands or had studied in the Netherlands, had the same pressure as in Western countries. So I realized you need to develop an eating disorders if you're vulnerable. So actually it's the vulnerability stress model, which was important in the schizophrenia research. So you have the link to schizophrenia. At that time, there was a lot to do about vulnerability stress models. And I actually realized that's probably the same for eating disorders. So you can be vulnerable by genes, also by sometimes prenatal events and by childhood maltreatment that has been proven at that time already in several studies, and especially sexual abuse at a young age and as a child, but also later in life, of course, has an enormous impact, this traumatic experience, to the risk of developing eating disorders. But so you have a vulnerable person. If there's no pressure, no social impact on to be slim, for example, but there are other factors important, then the risk of developing an eating disorder or anorexia nervosa, I should be specific, anorexia nervosa is small. And we see that in nowadays we do a lot of meta-analysis about in Africa and Latin America. You have done it in Asia and Arabia yourself. And we see that in Latin America and Africa, anorexia nervosa is a very, very rare disorder, while bulimia nervosa is the same frequency as in Europe and North America, and binge eating disorder is occurring even more frequently in Latin America and Africa. So if there is a pressure to be thin, you can you have a risk of developing an eating disorder, much more than if there's no pressure on thin. But of course, you have to be a vulnerable person to develop this eating disorder, this anorexia nervosa especially.
So, Hans, from a psychiatric epidemiology perspective, how important do you think it is to know how much is genetics and how much is environment? And can you really separate them?
I mean, in the beginning of this century, in the schizophrenia research, you had this idea, it's a matter of time, 10 years, before we know the genes for schizophrenia. It has not proven to be correct. We still don't know that. I mean, and for anorexia nervosa and other eating disorders, we don't know that either. I mean, we have a clue which genes might be involved, but there's no real answer yet. While we know that social factors and pressure, social pressure on adolescents are very much important. So we have a new study now conducted. We haven't published yet, but we have just submitted it to a journal, in where we followed for 40 years what's happening in the Netherlands with eating disorders. And we did find for the first time a significant increase in the young adolescent girls, 10 to 14 years old.
That's an increase in anorexia nervosa or all eating disorders?
In new cases of anorexia nervosa. Actually,
anorexia
the rates
nervosa.
of bulimia nervosa in the same study go down. But that's another story. For adolescent girls, it's hard to find something like that on a population level that has a real significant increase. And we are puzzled now, what could be the explanation?
Right.
Because overall, the incidence in anorexia nervosa has been rather stable over decades in the study, also in previous studies. And the only explanation I could find is the role of social media. We looked also at biological factors. So the age of puberty has gone down for about 3 months per decade. But that could only explain maybe 1 year after four decades. So the real impact, what happened in the 2010s, 2000 till 2020, when we find this finding, is the huge impact of social media. And internet is already longer there, but social media, this Instagram, for example, this is an enormous change in the impact all these adolescent women and boys also, but especially how young we are, this impact of all these images, this continuous peer ratings on all kinds of social activities and it has an enormous impact. We see also in the clinics that it has an enormous impact on our patients.
Hans, I'm really struck by the findings that you share from Curaçao and the most recent findings from the Netherlands, in that you are describing a very intricate relationship between biological or genetic vulnerability and social environmental exposures. And you said you wrote this paper, an early paper, saying anorexia nervosa is not culture bound, but you had to change your mind. Yes. So as you look forward and you see this dance between biology, genetics, maybe some epigenetic vulnerability that occurs, and environment, what are the particular either methodologies that we need to follow or questions that the next generation of researchers can or should be asking from your perspective?
I think the most important thing to do that is to do cohort studies. So follow people, children doing life, and see who develops an eating disorder and who not. And we're actually doing that in two cohorts. One cohort started at the age of 11 and is now in the late 20s. And we see what factors have impact on developing an eating disorder. And also follow a cohort, Generation R, Rotterdam, in Rotterdam, where we follow 8,000, the babies of 8,000 women, which we screened already before during pregnancy. So we made echoes, 4 echoes of the brain, and to see, and they're now 15, and we can see, we already did studies on picky eating and ARFID related behavior to see what's the impact on, and for example, the comorbidity of autism, autism spectrum disorders and eating behavior. So that gives a lot of information. I think people should follow that line of cohort studies are very informative. And also, I think, of course, especially for anorexia nervosa, good treatment studies to do randomized controlled treatment. Up till now, they don't show a lot of differences between the different treatment programs. So that's another line, but that's not specifically epidemiological, but it's treatment related. Yeah, but you use epidemiological methods to study that.
So cohort studies as a methodology, really following the biology and the environmental factors to tell a more full story.
Yeah.
So you started out saying you were really interested in tropical medicine. Yeah. You thought that early in your career, you're studying schizophrenia. Within 10 years, we would know the genetic basis of schizophrenia, and that would be the whole story. Of course, that hasn't been the case. Oh. Kind of similar assumptions around anorexia nervosa. There was a moment in time where we thought, we'll understand the genetic risk, and that's going to tell the story. It doesn't tell the whole story. Yeah. So as I hear it, your big idea around this interaction between environment and biology is quite nuanced, and nuanced around when biology matters, when environment matters, and how they interact differently for different expressions of eating disorder.
Yes.
Is that accurate?
Yeah, I think that's a quite good summary. I mean, if I look back, I think what helped me a lot, and that's what I also like myself to do, is that I had a lot of good mentors. Not at the beginning, like I told you about this first anorexia nervosa patient, I had nobody to go. But later in life, I had these good mentors in other countries like Tim Walsh, Janet Treasure, and others, and also in schizophrenia research. And that helped a lot, but also in clinical work. And later on, I had good mentors, supervisors, and I'm happy that I was always also able to train a lot of doctors. So hundreds of doctors have trained to become a psychiatrist. And that makes me happy and gives a lot of satisfaction. And my advice to young people in the field would be, look for good mentors. Don't invent the wheel yourself all the time. You have to find your own way, but you look for good mentors, which helps a lot. And what makes me happy is, for example, one thing I did was, I told you I did my first training in my first internship in Suriname. And at the end, I was able to, half of the psychiatrists, there are 10 psychiatrists in Suriname, and half of them are trained by me and my colleagues, which makes me happy that I had an impact. I had them come over to the Netherlands, trained them for several years, and then they are back now. And so education helps a lot. And so, yeah, for young people, get good training to become a psychologist, a psychiatrist, especially for eating disorders, because it's complicated.
You and I share an interest in looking at mental health, looking at eating disorders globally.
Yeah.
By doing the work that you've done in a variety of contexts, from Curacao to Africa to various parts of Europe, what's the particular value add of global work?
Advantage for other countries is to get training from experienced professionals, either in clinical work or research, to help them develop their skills and their programs. And we can learn a lot also from other countries, of course.
So just in wrapping up, Hans, I wonder if you have any further thoughts for the next generation of researchers, the new and next generations of researchers, questions that you hope they will take on and continue to address?
I think it's important. It's very demanding also to treat, especially anorexia nervosa. I see a lot of psychiatrists are not that much interested in it. They find it very frustrating to treat a person with anorexia nervosa. And they, you see, if a person with anorexia nervosa is admitted at a general ward, the team gets all kind of conflicts about it. So it's really hard to treat. So I think it's specifically a disorder which needs specialist care. So you have to be trained properly to treat people with eating disorders, and especially anorexia nervosa. Get good mentors, and be curious. Have this curiosity, this real interest in the patient. And I also say to the many doctors I trained, take care of yourself too, because I train more doctors than psychologists, but the doctors always say, take care of yourself first. You can only be a good doctor if you take care of yourself. Because if you're 24 hours on duty, you cannot be the 25th hour, you cannot be a good doctor or a good professional anyhow. And also more in a general way, take care of yourself also to, because it's tough profession, I think, psychiatry, psychology, clinical psychologist, and treating eating disorders requires, persistence, the same persistence as the patient has to continue this behavior. You have to have yourself to willing to treat and to try to help recovery.
Fantastic. Well, Hans, thank you so much for joining us today. We really appreciate your being part of this discussion, and greatly appreciate your willingness and your your persistence over the decades in terms of contributing as a psychiatric epidemiologist and clinician. You have really helped us understand a lot about the work we do and the folks who develop eating disorders.
Thank you very much for the opportunity to talk on this talk.
Thanks.